go out there and be a successful nurse, these are the things I need you to know today so you can safely give someone or educate them or whatever on their antibiotics. Okay, brief overview of our patho. Y'all know this is my thing, so I know I've had most of you guys in patho. So just review it. You have to understand why you're giving the antibiotics. Why are we giving antibiotics?
To treat bacterial infection.
To treat a bacterial infection. Do we do it for viruses?
No.
No. Okay, so we have to understand what we're treating, because what we're treating is going to influence how we're going to treat it, what antibacterial we're going to choose, right? So know that we have our bacteria, our different shapes, our bacilli and our cocci. So staphylococci is when the cocci appear in clusters, and then streptococci is when they're arranged in chains, okay? This is important, gram-positive, gram-negative. What does that mean from my patho piece? If they're gram-positive, what does that look like on a stain? Is it what color is it going to look when I stain a gram-positive? Purple, right? And then your gram-negative are going to look pink. But that is the difference between, are they aerobic or anaerobic? Okay. Let's see. Okay. So antibacterials are going to inhibit growth or kill bacteria and other microorganisms. Now we know antibacterials can kill all kinds of flora, even our good flora, right? It's kind of like the chemo drugs, like it affects all of the tissues, all of the cells. So your antibacterials are gonna inhibit growth or kill bacteria in all. It's not just exclusive to what you're treating, okay? So if I have a strep infection and I take antibiotics, the reason that you'll have some of the side effects that you'll have, like GI, which we'll talk about, is because it's killing all your good bacteria that we need in our body to function, okay? Antibiotics are the chemicals produced by one kind of microorganism to inhibit the bacterial growth or kill bacteria. So bacteriostatic means we're going to inhibit. Bactericidal means we're going to kill. Some drugs are bacteriostatic, not necessarily bactericidal, okay? So it means it may inhibit, but it doesn't actually kill the microorganisms. So they'll pair it with another drug that makes it bactericidal, okay? So there is a difference between those. For instance, penicillins are primarily bacteriostatic drugs. They can be bactericidal, depends on the dose, like how much you're giving, the serum level in the body, like that will make a difference in if I'm giving this antibacterial to an infant versus if I'm giving it to an adult. That will be different, right? And then also what pathogen you're treating. All right. So this moldy bread up here, so for those that did look into their reading, you learned about penicillin is originated from moldy bread. What they found is that these certain, what am I trying to say? They're not cells. What are antibiotics? These certain, they're not all mold. I'm trying to think of the right word to use. Organisms? These So what they found is that certain organisms, are going to inhibit the bacterial wall synthesis, or, they'll alter the membrane permeability, so the ability to get in and out. If it weakens that, then that means that things can get in there, right? So, inhibition of protein synthesis, which is needed for the bacteria to reproduce, and inhibition of synthesis of bacterial RNA and DNA. So we learned about, in patho, we learned about how viruses and bacteria, they can multiply and mutate and things. So this antibacterials, some of them work by prohibiting that action. So your antibacterials are going to work by one of these 5 actions. Some of them work by all of the actions. Okay, so many bacteria produce the enzyme called beta-lactamase. Okay, your beta-lactamase antibiotics, such as penicillins and cephalosporins, are trying to think of the way to. Okay, so the way our bacteria works is they work by one of these ways. They produce enzymes. If they are beta-lactamase enzymes, they produce this enzyme, then the antibiotics are going to be not as useful because that enzyme that the bacteria makes is not susceptible. So,
So beta lactamase, whatever, that's the enzyme out of bacteria.
it's the enzyme that the bacteria produces. So bacteria produces beta-lactamase, which is the enzyme.
So the enzyme's gonna just destroy.
And the enzyme destroys beta-lactam antibiotics.
Oh, okay.
So the antibiotics that we're talking about specifically are penicillins and cephalosporins. So if we have a bacteria that produces beta-lactamase, it's not gonna be useful, our penicillins and cephalosporins are not going to be useful for that.
So is it like cause it resistant to the penicillin?
Yes, but this is just a classification of those meds. Different bacteria can produce different enzymes, but yes, it does create a resistance. But that's only one of the, resistances, not, if it produces that enzyme, you can't use your cephalosporins and your penicillins because it's not gonna be effective. The beta-lactam enzyme is going to break down those antibiotics. Okay. We'll talk a little bit more about that as we continue on, and it'll probably make more sense, I hope. Okay, so our mechanism of action, alright, so antibacterial drugs, they must not only penetrate the bacterial cell wall in sufficient concentrations, but you also have to have an affinity for the binding sites on the bacterial cell. So all of this is to say that when we choose, which it's really not us prescribing, but when we choose our antibiotics, there's a reason that we're choosing those, because some antibiotics are not gonna work against some bacteria. And that's what I was saying with beta-lactamase enzyme that some bacteria make. Those antibiotics that we're gonna talk about, they don't work against that very well. So we'll talk about that more in depth about the varying levels. So what scientists have tried to do when we talk about different generations of medications in our antibiotics, scientists have had to work with that to try to make antibiotics that is not a factor. They're resistant to that beta-lactamase enzyme that bacteria produces, so that they can use that one. So, okay, so we have to have sufficient concentrations in the bloodstream. So, we have to have the right antibiotic, we have to have the right dose. All of that's gonna be important in actually being effective in treating, the bacteria present, right? Most of your antibiotics are gonna be once daily antibacterial dosing. However, sometimes you'll have to do multiple dosing. However, usually one-time dosing is sufficient to kill the pathogen. It depends on a lot of factors, but, basically we wanna do the lowest concentration to kill the bacteria, but to not kill our other good bacteria, and because that's not good for our body either, we need all that good bacteria. So we have our own body defenses that also play a role. So if I'm somebody that's already sickly, my own defenses aren't gonna kick into gear as well. So I may need more antibiotics, maybe multiple antibiotics to actually treat my bacterial infection. However, somebody who has a good, strong immune system, they may need less. So just know that this is a factor that plays into your antibiotic treatment as well. We have to look at where the client is now. What is their health status to begin with, and that will play a role in what's prescribed and how it's prescribed. Okay, so resistance to your antibacterials. So this is when you've given antibiotics, but the pathogen continues, or the bacteria continues to grow despite having those antibiotics. So some some bacteria have mutated and changed to be resistant to certain antibiotics. Those are usually our most common antibiotics that we have used, and over the years, because they have just been thrown out there to anybody and everybody that has a sniffle, a cough, a cold, when those are usually viral things. And the body, the bacteria senses that and builds up that resistance. They're smart, they're evolving. So one of those is, you have inherent resistance and then you have acquired resistance. So your inherent resistance is your beta-lactamase. Like, that is inherent. Like, penicillin is inherently resistant to beta-lactamase, antibiotics. Wait. No, hold on, take that out. Hold this. That's the opposite. That's the opposite. So your penicillin is inherently non-resistant to your beta-lactamase. Your beta-lactamase enzyme, your antibiotics, your penicillin, your cephalosporins do not work on bacteria that produce beta-lactamase. Yeah, enzyme, got it? No. Your cephalosporins, your penicillins that we're talking about, they do not,
Said they're non-resistant.
They're not resistant.
they are not, so they're not resistant, so they, God, I'm getting so confused.
The penicillin is not
Creating
resistant.
resistances, they never were able to work in the first place.
Yes, they can't create a resistance because they were never able to work in the first place. That sounds better than not resistant. Thank you. I was,
So they have the.
What page is it on?
so they're not effective. So your penicillins, if the bacteria produces beta-lactamase enzymes, and some bacteria do produce that enzyme, they're not gonna be effective. Your penicillins and your cephalosporins are not effective against treating those bacteria. Yeah. Culture, sensitivity, knowing, like, studying, like, knowing what bacteria is the antigen. Okay. Or you can have, so inherent is, the pathogen has this inheritance and say like it's, it says that Pseudomonas aeruginosa is inherently resistant to penicillin G. So you can't give penicillin to somebody with Pseudomonas aeruginosa. Okay, it's not gonna work. It's resistant naturally to it. You're inherent. Now, your acquired resistance, that requires previous exposure. So this is, I gave it to you when you had a virus, and then the bacteria learned, and so it changed and mutated to where that is no longer helpful. It doesn't work, okay? That's an acquired resistance. The bacteria has mutated to change to be no longer resistant to that, or no longer, susceptible to that antibiotic. One of those mutations is like a thicker cell wall, because that's how antibiotics work. If you go back to that slide, these are the 5 things that this is how antibiotics work. So one of those is that the bacteria has mutated to develop a thicker cell wall, therefore the antibiotics can't get in there to get to the bacteria. So you need to know your healthcare acquired infections carry a tendency towards resistance. The reason why is because it's a setting where we're giving a lot of antibiotics to a lot of different people and for a lot of different reasons for usually a long time. And so it's a setting to where that can develop. So most of these things that we're going to talk about have developed in hospital settings. You're more likely to get them in a hospital setting. However, they're getting out into the communities now too. So those bacteria are methicillin-resistant Staphylococcus aureus, MRSA. Now, have y'all been at clinical and you've seen like, what kind of precautions do you have to do? Contact. So do I have to wear a mask for contact? What kind of mask? Do I need an N95 mask?
No.
No, just a regular surgical mask. So, the other one's VREF, vancomycin resistant enterococcus, and VRSA, vancomycin resistant Staphylococcus aureus. So, and then we're constantly dealing with this battle because as new drugs are developed, so do new strains of resistance. So, the reason, why are you on contact precautions? Like when somebody has MRSA and you're going to take care of them, why are we on contact precautions?
It's not
Spread it.
It's not airborne, but yeah, we're worried about spreading it. So not only are we worried about getting somebody else sick, we're worried about getting someone else sick or ourselves with MRSA. So, and there's only so many antibiotics that can work. Well, what if the only thing that I can get is what I'm allergic to? So the reason, that's the problem with our resistance is that, you get down to your resistant antibiotics and they are not, you have a tiny handful of antibiotics that are gonna work. Well, what if there's nothing else we can give you? Every antibiotic is resistant to this bacteria. Like, there will come a day when that's going to happen because things, so antibiotics, the science of antibiotics is constantly changing because we're constantly trying to make new, by understanding like the beta-lactamase and the specific kinds of resistance, so that we can continue to hopefully have some things that can treat these bacteria as they evolve. Okay, how do we know if they're resistant? You come in and you have an infection on a wound on your foot. What do we do to it? We're gonna culture it, and then what else goes with the culture? So the culture comes back and it says it's a gram-positive staphylococci. Okay, so then what else comes with the culture? We do it's called a C and an S. C and S. What does the S stand for? Sensitivity. Okay, that's important. So when you do a culture of a wound, you send that off to the lab and they're gonna tell you, okay, they're gonna put it in a petri dish and they're gonna grow it, literally. And they're gonna grow it, and if nothing grows in 7 to 10 days, it's negative culture. Or it'll be like normal flora. And they'll say, okay, no infectious bacteria grew, normal flora. Okay, good, negative. But if it grows that gram-positive staphylococci, then they're gonna say, hey, they have this. It's likely to be, maybe there's 2 things that are gram-positive staphylococci. I don't even know, I don't want y'all to know that, but just say it's E. coli. I don't even know what shape that is. I think that's a rod. Anyways, but just say it grows E. coli. Well, then we have to know what antibiotics can I use to treat that E. coli infection. What is it gonna respond to? Okay, just because it's a gram-positive staphylococci doesn't mean that all the antibiotics are gonna, you may have a resistant strain. Okay, so that culture and sensitivity is important. Do I need to go ahead and treat their infection before? They came in, they have a raging infection on that leg. Do I need to treat that? Or should I wait? What should I do? I mean, you told me it takes 7 to 10 days for this culture to grow so that I can know. So what do I do?
You could try treating broad spectrum.
A broad spectrum antibiotic. So a broad spectrum antibiotic is gonna cover a broad range of different bacteria, okay? Now, if it comes back and it's only sensitive to, cephalosporins, well then okay, well I can't, if I give it a penicillin, it's not gonna do anything. If I give it this other antibiotic, it's not gonna do anything. What I need to do is give it what it's sensitive to. So what they do in that petri dish is they start hitting it with antibacterials and seeing what does it respond to. Well, didn't respond to that, didn't respond to that. Oh yay, good, it responded to this. And so you get that report and it looks like this is the bacteria and this is the sensitivity, okay? So that's important. If you don't have that sensitivity aspect, you're just throwing, yes, we know what bacteria caused it, but bacteria, you have learned in this lecture, are mutate and have different strains of bacteria. Even if it's E. coli, there's different strains of E. coli. So we have to know exactly how to treat it best. So with your methicillin resistant, or your VRE, those bacteria, you can't use any methicillins, you can't use any, like VRE is vancomycin resistant. Vancomycin was one of the things that used to treat everything, like in well. But when you use broad spectrum antibiotics like that, that's when you run into the broad spectrum antibiotic resistance. So, yes, if you have somebody that has an infection, we do have to start treating them. We can go ahead and do we do it after or before we collect that culture?
Before. After?
Oh, well, yeah, I guess. You have to take your culture first, y'all. This is test question antibiotics 101, okay? If you don't learn anything from today, you learn this, okay? You have to take the culture first before you can give them anything. I don't care if you, well, I just started the antibiotics 2 hours ago. No, you have to get the culture before. Send the culture down, then you can give them that broad spectrum antibiotic, okay? Because then if you don't know what you're accurately treating. You don't want to have to give somebody multiple antibiotics back to back, because what did I say it was doing in there? It's not only affecting your bad bacteria, it's affecting your good bacteria that you need for your normal functioning of your body. So, you're gonna collect that culture or C and S, culture and sensitivity. They go hand in hand. You're gonna collect that, you're gonna send it down, and then you're gonna treat them with that broad spectrum. Where you get your C and S report back, and it tells you that it is sensitive to penicillin. Okay, so then I know that I can give penicillin to this client because it is sensitive, that bacteria is sensitive to that, which means it's responsive, it will kill it. Okay, so don't get that twisted as far as like what sensitive means. When your sensitivity comes back, what it's sensitive to means what will kill it. Okay? All right, so the problem, with so we talked about resistance, and there's antibiotic misuse. We talked about taking it for viral infections, taking them when no bacterial infection is present, even if you can have a fungal infection. And so you need to know what you're treating. That's why when you go to the urgent care or whatever, because you have a cough and you're like, I think I have I don't know, a sinus infection or something. Well, if you don't truly have a sinus infection, we don't want to give you an antibiotic because of this. There's an overuse, and there has been a tendency in years prior to just write a prescription for everything. And that has caused a lot of problems because it is decreasing the amount of antibiotics that we have for bacteria that is present in the community. It's outdoing our antibiotic production. As far as what is sensitive to it. So taking antibiotics incorrectly, skipping doses. So another, if you don't get anything from today, at least get this. Can I stop taking the antibiotic when I feel better?
No.
Why?
I was always told not to.
Because my body could build a resistance to it, because it could create, that bacteria could become resistant to it. Even though I feel better, that bacteria is still present and it could create that resistance to it. So, yes, you never want to stop your antibiotics unless it's prescribed. Like if you have 10 days of antibiotics, you have to do the whole 10 days, even if you don't feel better. Okay, that's an important teaching point for our clients. Because that is day 2, 3, you're feeling better, but then you stop taking it. And that's how you develop resistance. And the bacteria develops resistance. Cross resistance can also occur. That's where, I'm not gonna go into all that. It's not likely. Okay, so remember I talked about like if we, you have antibiotic combination effects. So some of them are just, bacteria static. So if I give,
The one that you just skipped over, I don't wanna read it, I wanna have to read it. So,
Okay.
is that the cross resistance, or, I mean, what did you say, you don't wanna go into all that?
yeah, it's not likely to happen, so it's a good to know. Don't, I mean, read that, but like, I would not,
Trust rate.
yeah. You're not in my pathway class.
No.
So, yeah, I try to tell you like good to know and need to knows, and if I'm like, like, it's, I mean, I make my test questions for this, so I'm trying to prepare you guys and actually know some of it, because I mean, if you're just trying to read the book, you ain't gonna, I mean, how much of that can you actually retain?
Right.
But like, leaving here today, I think you could take at least maybe like 2 things and be able to be like, I learned this and this. Or maybe you knew it, but, you know, it refreshed it. Those are the important things. Okay, so your antibiotic combination effects. So you have an additive. So remember how I said they'll add like a bacteriostatic, like penicillin is typically a bacteriostatic, but in higher doses, or if it's you add another medication to it, like this is, oh god, these, ceftazidime, and avibactam. So those are 2 different drugs. And, but they have an additive effect, okay? So they help to, the effect is doubled. Potentiate means that one potentiate or increases the effect of the other, okay? And antagonistic means that, when one bactericidal and one bacteriostatic are added together, the desired effect may be reduced. So that's something that we wouldn't want. We wouldn't want to put 2 together that actually antagonize each other. So I said usually a single antibiotic, usually a single antibiotic will successfully treat a bacterial infection. However, when severe infection persists, is of an unknown origin or has been unsuccessfully treated with one, then they will do like multiple. But in most cases, you're just given one antibiotic. And ideally, we have a CNS to know exactly what will treat it.
So this medication is an additive or is it an antagonist?
I don't know. That is just to say that you can put 2 antibiotics together and they have one of these effects. I don't know exactly what that one is, and I don't want you to know. It's just to show that 2 antibiotics can have one of these effects. So sometimes they'll pair them together, but most often it's just one. Alright, general adverse reactions. Okay, so you're gonna your biggest things, and this is for all your antibiotics, like, guys, we're only talking about 3 classes of antibiotics today. When you go to your your Pharm 2, you're gonna talk about lots more antibiotics. There are so many antibiotics out there, even within the classes. So I want you to understand as a class, as a whole, what they do, what they typically treat as far as gram-positive, gram-negative, am I beta-lactam resistant, like that kind of thing. Okay, so your allergic reaction, your superinfection, and your organ toxicity are gonna be your 3 biggest things. It varies. So allergic reaction is your most common finding. It can be anything from a mild rash to full-blown anaphylaxis. okay? However, it is your most common finding, so sometimes you can have just a mild rash, and that's normal. So that's fun, right? Normal, abnormal. So it's your most common thing, is you could see a rash. It might be life-threatening, or it might just be normal. Right? I know. So, what that requires is for you to educate your patient, know what kind of rash it is. If you see this kind of rash, urticaria, do you guys remember from patho? Your urticaria means allergic, versus just I just have like a little bit of a mild, like just little bumps that appears. You know, I feel fine. Like, that can happen because it's a hypersensitivity reactions are common. Now, if you have urticaria, I'm gonna be like, okay, we're gonna stop taking that. So you have to know that, kind of back to your patho, like this is a normal rash and it's not affecting anything else and it's okay, versus this is, no, your next step looks like anaphylaxis. But it's not just gonna be urticaria, like they're gonna be maybe itchy, maybe panicky feeling, there's gonna be other symptoms. So, but if they're okay and they just have a mild rash, then that just might be a side effect of the medication. How wonderful, right? Normal side effect, severe adverse reaction. It's up to us to gauge what they are. Does everybody follow that? Like, understand what I'm saying? Yeah, no?
I'm just winging it.
Well, I don't want you to just wing it. Rash is the most common side effect, okay? Also, GI disturbances. However, if I have, what happens when I've taken antibiotics and it kills all my good bacteria in there, and then I get this bad bacteria called, anybody? C. diff. So that's that's an adverse reaction, right? A little GI upset, like, okay, it happens. Like, anybody that's ever taken antibiotics, you're like, my stomach just ain't really right. That's a normal side effect. However, the severe side of that is that it can deplete, especially if you're already immunocompromised, it can deplete all of your good bacteria in there, and then you get C. diff, which is an infection of the bad bacteria that requires, ironically, antibiotics, but a specific antibiotic, okay? So just know that in your side effects, the common things range from common, normal, not gonna, this is just something we have to cope with, to C. diff, anaphylaxis, full-blown hypersensitivity reaction, anaphylaxis, angioedema, remember the lips? So that's up for you guys to be able to assess and differentiate. Is this a normal side effect of the drug, or is this a adverse reaction? Okay, so you might get a question and it might talk about that, but it's not gonna be like, oh, well, they had a mild rash and angioedema. Like, those don't go hand in hand. Like, it's gonna be like the patient has angioedema, urticaria, complaints of feeling, it's gonna be obvious. I'm not gonna put like a normal side effect with a severe, because your severe aren't just gonna be isolated. If you have a reaction, it's gonna be a systemic, because those antibiotics are going systemic. Okay? Make sense? So superinfection is like your C. diff. That's when your bad bacteria overtakes your good bacteria. Most common C. diff, and then Candida, your yeast infections are going to be your most common, other than C. diff. That's your superinfection. So normal flora is killed. Usual places are mouth, skin, respiratory tract. And then GI tract intestines is your SIDO. Organ toxicity, so at certain levels, the antibiotics can be, like, some of them are more prone to, create a specific organ toxicity. The ears being one of them, you will learn more about that. You will know if any of the antibiotics that we're talking about are toxic to at high levels for hearing. Spoiler alert, it's none that we're gonna talk about, okay? But you need to know, just in broad, about antibiotics, because this is the beginning of our antibiotics. You'll get the part 2 of antibiotics in Pharm 2, okay? So this is just general overview. So, out of all of them, when you list your side effects, they're pretty much all gonna be a lot alike. You're gonna have GI disturbances, you're gonna have rash, like, you're gonna have those things. Remember I told you that they're the most common with all antibiotics, not just the ones we're talking about. Now, there are gonna be certain things about certain ones where maybe it's hepatotoxic or like, and that you will need to just put in there outside the norm, okay? But all of your antibiotics are gonna cause rash, can, like, you know, not going to, but can cause a rash and can cause, GI disturbances, yes, they will. Sometimes it just like, it just goes blank in there, you know, and I'm just like. Okay. Alright, why don't you guys take a quick break? Do you need a break? No, okay, don't take a break then. Oh, she's got it, she said yes. You can just take a quick break.
I'm gonna do
5